To date, we have gathered valuable input through rural outreach. We went on a tour of the rural hospitals. We visited 13 hospitals last fall to gather input on the expansion. We also did a request for information in July of last year that closed, I think, in October of last year. All of the stakeholder members of the public were invited to submit responses. We received 30 responses, which we were very happy to see. Of those 30 responses, about 27% of them were from health plans, 40% were from providers and provider associations, and then 30% from other respondents. Key themes from the stakeholders are summarized in the next section of the presentation. Over the coming months, we will share additional information, answer questions, questions, gather input to inform the Medicaid managed care program expansion and the new contract. We will do that through rural outreach, meeting with key rural stakeholders to better understand their healthcare challenges facing the rural communities, and we will be holding at least one additional public workshop depending on the need, and again, gathering additional information to inform our process for developing the RFP. Moving into the stakeholder feedback that we've received to date. For our discussion today, next slide, please. Thank you. For our discussion today, we've grouped the stakeholder feedback collected from the request for information and the rural hospital listening sessions into these 6 major categories, which we'll walk through one by one. For each theme, we'll outline why the issue is of particular importance to Medicaid managed care expansion, provide a high-level overview of the stakeholder feedback we've received on the issue to date, and invite additional feedback from the participants here today. Next slide, please. So the first key area is provider networks, and the reason that these are important for the managed care expansion is that improving access to care is essential to ensuring a successful managed care program, especially in our rural and remote communities. Many Nevada providers do not accept Medicaid due to low reimbursement rates or related administrative burden. Many members face long appointment times or travel times, especially for primary care and behavioral health care, and in the rural and frontier areas of the state. Of note, one of the broader challenges for Nevada is that all 17 Nevada counties are under one or more federal health professional shortage area designations. And I would like to now introduce Juliet Mullen, Director with Manat Health, who is our contractor that's assisting us with developing this RFP. She's going to talk through some of the feedback that we've received thus far.
Great, thank you so much, Jamie. Our team had the great opportunity to go through all of the feedback submitted through the request for information and via the Rural Hospital Roadshow, as Jamie mentioned. And what I'll do today is walk through some of the feedback that was received in the provider network section. So I'll walk through the feedback to date, and then we'll actually pause for a few minutes to hear any additional thoughts or comments about this feedback or other suggestions and ideas that the group has today. So for provider networks, what we did is we categorized the stakeholder feedback into 3 main buckets, as you can see here. So the first is adequacy in rural areas. And on the slide, what we've done is we've provided some high-level examples of what was included in each of these buckets, but I'll take a moment now to go a bit deeper. So when it comes to adequacy in rural networks, stakeholders really emphasize the importance of a few things. The first is clarifying and promoting the use of telehealth services in rural areas. For example, recommendations submitted in the RFI included encouraging the use of telehealth services to increase access to specialty services. And, more specifically, even examples included things like incentivizing the use of teleconsultation agreements between rural providers and urban specialists or specialists where they are located. Stakeholders also identified issues around the payment rate as a potential barrier to developing provider networks in rural areas. So to that end, the division received recommendations, for example, to set rural specific rates or to consider a floor for rural rates. Stakeholders also suggested encouraging higher rates for specific types of providers or specialties that were experiencing the most significant shortages. So for example, EMS, behavioral health, pediatrics, et cetera. And finally, in this bucket around rural network adequacy, stakeholders recommended setting region-specific network adequacy standards. Examples of specific ideas that were suggested were, for example, developing provider requirements that align with CMS standards specific to rural areas, establishing mid-level practitioners and really adding more guidance around how you incorporate mid-level practitioners into provider to member ratios, and establishing rural post-acute care service levels. So these are some examples. I will just note that the Division of Healthcare Policy and Financing has posted all of the RFI responses on the website. So invite folks that want to see additional recommendations and details around that to go ahead and look at all of the really, really great details that were submitted in the RFI responses. So next I'll go to the second bucket here, which is a more broad call for, oh, sorry, we could go back to the previous slide. Still on the slide we were on, thank you. Which is support for providers statewide. And so here it was really thinking about how to grow provider networks writ large, and stakeholders identified the specific issue around administrative burden of participating in Medicaid as a significant barrier for providers. So this included things like needing to meet administrative requirements associated with provider enrollment, with authorizations, billing and payment, and with plan-specific documentation requirements. There were a number of different suggestions around how the state might consider streamlining administrative requirements. They included things like simplifying the credentialing and provider enrollment process or streamlining authorization policies. And in that final bucket on this slide here, there were a number of recommendations from stakeholders around how the state might bolster the healthcare workforce, both through recruitment and retention efforts. So there were a few different very specific suggestions received through the RFI. I'll share a few examples. Stakeholders recommended, for example, offering incentives for workforce retention, such as funding for continuing education, loan support, and other financial incentives. There were also suggestions around how Nevada might leverage agreements with out-of-state providers to increase access, things like reciprocity agreements or reducing barriers for out-of-state providers to become enrolled in Nevada Medicaid. And then lastly, we heard recommendations around growing the workforce of allied health professionals, such as community health workers, physician assistants, to help bolster access, especially in rural and frontier communities. I have now spoken a lot. I'd love to pause at this moment and invite broader feedback from this group around this particular theme on provider networks. I'll just note we'll touch on a number of other themes subsequently in the session today, but would love to open the floor on provider networks and invite folks to raise their hand, to use the raise hand feature if they have any questions or additional comments or suggestions on what is listed here or ideas on how the state might approach provider networks in the 2026 contract. I'm going to see if we've got some raised hands. I see we've got some raised hands. It looks like our first hand raised is Jeremy Reeves. And I think, Jamie, keep me honest, are people able to unmute themselves? Do we need to unmute them? Oh, it looks like Jeremy's unmuted, so.
Have you checked with other states that have rural networks for best practices and lessons learned that could be applied and adapted for Nevada?
you want to speak to that one, Jamie? Would you like me to?
Trying to get off mute.
Always a challenge.
Right. At this point, Nevada has not necessarily reached out to other states, but we've just started our process with Manat Health Strategies, and they have access to a lot of that information that we'll be going through as we're working through identifying these areas.
Wonderful. Thank you, Jamie. Next in line, we have Erin Lynch.
Hi, good afternoon. Are you able to hear me?
We are.
Okay, great. Hi, I'm Erin Lynch. I'm with the Nevada Hospital Association. And the Nevada Hospital Association recommends the following, as this could impact provider networks, especially rural networks, if providers choose to not enroll or to disenroll from the Nevada Medicaid MCOs. So a few of these recommendations are that we recommend that hospital reimbursement rates must be at a minimum of the fee-for-service rates and not below. We recommend that when a patient needs to be transferred from one hospital to another facility, we recommend that hospitals still be reimbursed at the med-surg rate and not the admin day fee, as services are still being provided to Medicaid recipients. We also recommend that prior authorizations must be processed within 24 hours of the request. We recommend to allow for retro prior authorizations, especially since rural hospitals can have administrative staffing shortages while trying to follow different prior authorization rules with different health plans. We recommend to allow for universal prior authorizations, especially when a service is authorized on one MCO and then the Medicaid recipient switches to another MCO. So that would be really helpful. We recommend that all MCOs must follow all the policies that fee-for-service providers must follow, such as like prior authorizations, billing procedures, appeals procedures, etc. As you know, rural hospitals do not have the staffing power to follow, let's say, 5 different policies from the fee-for-service side over to the MCO plans. That can be really burdensome. And we also recommend that the state monitors denials by all of the MCOs. So thank you so much. I appreciate the time today.
Thanks, Erin. Appreciate all of that feedback.
Thank you. I'm going to go to the next person in line in just one moment, but I do also want to put in a brief plug. I see we have a number of folks that have joined us by phone only today. If you would like to raise your hand to provide a comment or question, you can dial, just a reminder, you can dial *5 on your keypad. And our next person in line is Stephanie Moncada.
Hi, good afternoon. Can you hear me?
We can, yes.
Okay, great. My question is around telehealth promotion and kind of thinking about what challenges would arise in the frontier counties and how you're thinking about that.
We're definitely looking into telehealth and how we can implement that well in the rural areas. That's one of the key areas that we're focusing on with Manat. As I mentioned, we've just started our process with Manat, and we'll definitely be focusing on that area. If you have any recommendations, we welcome you to provide that information to us as we work through this process.
Thank you, Stephanie. And next in line, we have Shauna Ross.
Hi, am I off mute?
Yes, you are.
Hi, I'm with the Nevada Speech and Hearing Association, and I just wanted to make a comment about including allied health professionals, including speech therapists, as part of the rollout and keeping us in mind in regard to payment and prior authorization. And we also ask for payer parity across sites. So, for example, right now, provider type 60, which is school-based services, and is reimbursed at a higher rate than provider type 34, which is private practice. So we just asked for that consideration and to be included in the discussion. So thank you.
So the only thing I would just say there, I just want to be mindful that managed care doesn't mean we can add a lot of new requirements that increase our budget. So there's only so much we can do. If that's something you really want, we need to talk about legislative session for funding. I just want to be realistic about what this is.
Okay.
Thank
So just like the hospital-based person mentioned, if we can have rates that are similar to the fee-for-service rates, because right
So-
now
Yeah.
there is a adequacy issue. I don't know if it's appropriate for me to say, but there is one specific MCO plan that reimburses lower than the Medicaid rate. And I know that there's a real access to care issue in Northern Nevada. So those are just some of the things that we're seeing when we get calls from families as being a barrier.
That's helpful. We are looking at ways to make sure that plans are at least paying the fee schedule. I can tell you that.
Okay, great. Thank you.
And it looks like we've got another hand raised. The name is DE. I'm off mute.
Yes, I also put my comment in the chat, but I didn't know if you guys were monitoring the chat. Hopefully, now that it's going to be in the rural areas, hopefully they will not allow the MCOs to capitate with only certain providers, because it will then limit even further access to the care if the MCOs are limiting what providers can even be in network, especially in the rural area.
Thanks, Dee. We appreciate that feedback as well.
Thank you.
Not seeing any other hands raised or comments in the chat at this time. And so I think, Jamie, if you have no additional comments or thoughts on this one, we can probably go to the next.
Thank you. So the next key theme that we're focusing on is behavioral health care. Nevada, like most states, has a significant gap in its behavioral health care system. Those gaps are exacerbated in rural and frontier areas of the state with the remote nature of the communities, and especially among pediatric populations. One example is that the U.S. Department of Justice issued a recent finding that Nevada is out of compliance with the Americans with Disabilities Act with respect to children with serious behavioral health conditions. It's an area that this state is focusing on heavily. So I'll turn it back over to Juliet to go through the feedback we've received thus far.
Great, thank you. So in reviewing all the feedback that's been submitted to date, I think, at a high level, we've summarized some of the core recommendations here. I will also just note, as you can imagine, there were a lot of recommendations in the behavioral health domain, if you will, that also cross over into some of what we shared previously on the provider network slide. So you'll hear a little bit of repeat there. And just to note that there's also a lot of rich information in the RFI related to behavioral health provider networks that were summarized in the previous slide as well. But with that in mind, I will note that one very consistent theme across the behavioral health feedback received from stakeholders was around telehealth, with stakeholders recommending the state facilitate the use of telehealth services for behavioral health to improve access to services, especially in rural areas. So to offer a few examples there, stakeholders recommended that the state establish coverage and payment parity for telehealth behavioral health services, as well as offer support or incentives to providers to build out telehealth infrastructure, for example, to help them acquire tablets, software, et cetera, in their practices to support telehealth for behavioral health. Stakeholders also emphasize the importance of reimbursement for audio only services, remote patient monitoring, and two-way texting. We saw that kind of across multiple different domains in the RFI. And they shared the importance of prioritizing broadband expansion in rural networks. Again, that was one that was kind of across multiple of the different themes in the RFI. Stakeholders did recommend revisiting payment rates for behavioral health services and considering lifting prior authorization requirements for certain types of behavioral health services. And finally, we noted that several stakeholders proposed promoting the use of specific evidence-based behavioral healthcare models. Some examples that were offered in the RFI included patient-centered medical homes for behavioral health services, the collaborative care model, certified behavioral health model, and peer support models. So that's kind of a very high-level summary of some of the feedback received on the behavioral health sections of the RFI, but would love to, again, turn it back to you all to hear more on your thoughts, any reactions to these suggestions or additional suggestions you'd like to put forward for the state to consider. I'm gonna go look at the metaphorical line again to see if anyone has raised their hand. If you're joining us phone only, just a reminder to get in line, you'll want to dial *5 on your keypad. We'll just give it another moment here to see if people are taking a minute to find the hand raised functionality. Which I know we're all operating between multiple different technical platforms on a day-to-day basis, and it can take a moment to orient yourself. So
I do see a question in the chat about how to get a copy of the presentation, and the presentation is posted on the public notice webpage. We'll go ahead and put a link to that page in the chat. Thanks, Leah.
just take a final moment for a final call on hands, if anyone would like to provide a verbal comment.
Do you want me to read what's in the chat, just so you guys hear it, if we want to talk about it
Sure.
all? It says for behavioral health consideration to expand MAT treatment-based services to coverage beyond OUD, including meth and alcohol. Just thank you, Angela.
All right. I think if there are no other comments or questions on this set of feedback, we can probably move into the next theme.
The next theme, maternal and child health. Nevada Medicaid continues to strive to improve maternal and child health outcomes. The department uses several contract tools to improve access and care for children and prenatal and postpartum individuals, including performance improvement projects that the MCOs conduct. We have a 1.5% withhold on capitation payments that the MCOs are eligible to receive if certain metrics of improvement are met for this population. We have a quality-based algorithm for the 2024 and 2025 contract years that prioritize new member assignments based on plan performance on HEDIS metrics for prenatal and postpartum care, as well as well child visits. We also have a bonus payment program for the 2023 contract year that increases the percentage of total expenditures on primary care providers and services, which may include pediatric and obstetric care. And I'll let Juliet go ahead and take the next slide and go over the feedback in that category.
Great, thank you so much. So on maternal and child health, we pulled out 4 main themes or buckets of feedback from the RFI and the Rural Roadshow. And they really covered access to care, benefits, care coordination, and social determinants of health, and payment. All very big buckets. So let's take a moment to dive into them. So on access to care, as with other themes we've discussed today, stakeholders emphasize the importance of a robust healthcare workforce in the maternal and child healthcare space in order to really ensure that there's going to be adequate access to care for members, especially in the rural and frontier areas of the state. So to that end, as we looked through the specific recommendations from stakeholders, some examples included a suggestion that the state explore ways to invest in workforce development for maternal and child health providers specifically. And some examples there were having incentive programs for maternal and child health care providers in rural areas to participate in Medicaid managed care, as well as incentives for hospitals to achieve birthing friendly designations. So a number of different examples like that were included in the RFI. Stakeholders also recommended providing targeted education and training programs specific to maternal and child health providers, including but not limited to doulas, midwives, and other allied health professionals. One other big area that was highlighted here, which again we saw in the previous two themes as well, was the importance of telehealth to improve access to maternal and child health recipients. A few of the specific examples for these members included promoting remote patient monitoring and two-way texting services, especially for individuals with high-risk pregnancies in rural areas. Another example that we mentioned on a previous slide as well, but I'll double click on here again, is the incentivizing of teleconsultation to connect rural providers with specialists in more densely populated areas. Specifically for rural areas where a specialist may not be available. So that kind of covers some of the core feedback around access to health, but again, encourage folks to take a look at the more detailed RFI feedback if you're looking for more examples in that theme. There's also a number of different suggestions around how the state could enhance or improve benefits in the maternal and child health space. For example, there were some suggestions on strategies to increase the use of the doula benefit. So examples there included re-examining reimbursement rates and payments for the doula benefit and providing training to perinatal care providers and members of the community on the importance of doula services. Additionally, some stakeholders emphasized the importance of dental benefits for the pregnant and postpartum individuals, including the need for ongoing dental coverage for an extended postpartum period. There were some recommendations around covering home visiting programs for members with limited access to health centers, as well as suggestions to construct a comprehensive plan for maternal health that includes services such as group prenatal care, lactation support, benefit consultation, and universal screenings. In the next category here, we have care coordination and SDOH, social determinants of health. In this space, we received responses recommending that the state further promote different evidence-based coordinated care models for maternal health. And so two examples that were specifically called out were maternal health home model and the Pathways Community Hub model. Stakeholders here noted that these models could enhance continuity of care, especially for individuals in rural areas, starting with prenatal care through birth and into the postpartum period. So a number of recommendations there around kind of coordinating that streamlined care across the birthing experience. Stakeholders also provided input on how Medicaid could more robustly address social determinants of health for maternal and child members. Some examples there included creating incentives such as payment per screen completed for pediatric providers to conduct SDOH screenings during child wellness visits. Another example was providing non-emergency transportation options to help members such as especially pregnant members in rural areas access care and access social services. And then kind of in support of both improved care coordination and the support for SDOH, stakeholders recommended stronger partnerships with community-based organizations and bolstering the community health worker workforce. Finally, I'll note there was a payment bucket here. Many respondents highlighted the importance of having sufficient rates and establishing an adequate provider network for maternal and child health. And they suggested that the state consider some unique rates for certain provider types and specialties experiencing shortages, which is a similar theme we covered in the provider network bucket earlier in our session today. And some particular examples here included suggestions to, for example, widen the eligibility of the pediatric enhancement rate and a recommendation to explore bundles payments that cover care during pregnancy and throughout the postpartum period. I feel like I've just talked a lot, so I'm going to stop now and see what reactions folks have, additional suggestions, if there's anything here you want to double click on and really highlight for the state to think about. And again, we invite folks to raise their hand using the raised hand function in Zoom if you'd like to ask a verbal question. If you've joined us by phone today, you can dial *5 to raise your hand, and we'll call on your phone number essentially to bring yourself off mute. Also provide comments in the chat.
Hi, Juliet and Jamie, this is Liz. I do want to flag we received a comment in the chat. It is from our prior topic in the behavioral health space. I just want to take a moment to share it with everyone while folks digest all the information that was just shared on maternal and child health, give you all a moment to think. But I did want to acknowledge Matt's comment from the Nevada OT Association, seconding some of the comments made from Allied Health and Dee's considerations. But Matt, as you said in here, the hope is that occupational therapy, both evaluators and assistants, are practitioners with mental and behavioral health services in their scope of practice, hope to be utilized, especially in telehealth and adult services, also inclusive of substance abuse. Expressing enthusiasm to be part of the team as the services expand. So thank you, Matt, appreciate that. And I see one more question in the chat. This is specific to maternal health, so I'll go ahead and read it out. Thank you, Jerry. Oh, Stacy is responding in real time.
Sorry.
No,
Can I
go
just
ahead,
chime in?
Stacy.
Thank
That's
you.
great.
I would just say we obviously want to go for everything we can, but we're just trying to be reasonable about what we can achieve and whether or not we could achieve this model and whether or not we have the capacity. So we're still reviewing it. Unfortunately, we just have a lot on our plate. And sometimes when you get a grant, it comes along with a lot of other things that we may or may not be staffed and completely able to do. So it is on our list. We're reviewing it, but we have no answer at this time.
Pause here for another moment longer to see if anyone wants to raise their hand or share an additional comment in the chat. All right. I think that probably means that folks feel like this feedback covers the core of the feedback they have. If something comes to you as we move further along in our session today on this topic, please feel free to drop it in the chat and we can come back to it in the upcoming comment and Q&A moment. So I think with that, we can go to the next theme.
Next theme is market and network stability. For the upcoming expansion and procurement, we are examining our approach to service areas and member assignments. With a goal of providing greater market stability, access to care, and quality MCO choice, Medicaid is considering whether all contracted plans should serve the entire state, or if the state should establish specific service areas that may be served by different combinations of MCOs. and also weighing how to match members to MCOs in the new contract. For our 2022-23 contract years, our initial member auto assignment process was designed to prioritize equitable distribution of membership among MCOs. And moving into the 24-25 contract years, the initial member auto assignment process is based on MCO performance on select quality measures, as mentioned earlier. And I believe that we are looking at no more than 4 plans statewide and no more than 2 plans in our rural areas. And I'll go ahead and turn it back over to Juliet to talk further about the feedback we've received so far.
Great, thank you, Jamie. So I think on the very first question, which is that question of whether the state would have one service area, which is to say a Medicaid managed care plan will cover the entire state, or there would be multiple service areas. As Jamie noted, there would be some plans covering different parts of the state. So in reviewing the stakeholder feedback to that particular question, there was not really a clear consensus. There were different varying positions on this, on whether having a single service area or varying service areas would be the path forward, should be the path forward for the next contract. One piece that stakeholders did elaborate on here quite a bit were the various pros and cons of each of these approaches. I'm not going to go through everything that folks shared here because we'd be here for quite a while. There was a lot of great feedback, but I will note that as we thought, in thinking about the idea of having a single statewide service area, some of the pros that were lifted up were really being able to develop a statewide provider network that might make it easier for enrollees to access care statewide and not just in their counties and region. There were some call outs around it potentially having a benefit around continuity of care, especially as members move, and that it may minimize kind of a statewide and at the MCO level, the administrative burden and jurisdictional challenges that you might see. Some of the cons of that approach, though, would be that it might increase the administrative burden for rural providers managing operations with multiple MCOs in the rural counties. Another con that was called out is that it might result in a one-size-fits-all model that wouldn't adequately address rural needs. There were some questions about whether resources would be distributed equitably across such large service area. So lots of different pros and cons. I encourage folks to take a look at the more detailed responses if you're interested in hearing more. But lots of stakeholders weighed in on the different advantages and disadvantages of having a single service area. Similarly, folks provided pros and cons of the multiple service areas. And some of the pros of having multiple service areas would be allowing for tailoring of services and programs to specific regional needs, incentivizing the development of local and rural funding opportunities that address the unique needs of different service areas. So those are some of the major advantages called out there. Some of the potential downsides to having varying service areas and having different MCOs in different counties is that it might increase some of the fragmentation of the provider networking system, especially for members who are moving. And then again, just encourage folks to take a look at the more detailed list of pros and cons that were provided by different stakeholders. So that's on that first question. On the question of the member assignments, again, here we had a number of different ideas suggested by stakeholders on how the state might consider setting up the assignment algorithm for members and new members across the different MCOs in the new contract. Some examples included tying performance on quality metrics to assignments, thinking about how you might be able to prioritize MCOs that demonstrate a thorough understanding of the local health needs in the areas that they're operating, looking at opportunities and ways where you might be able to match members' care needs to provider networks who are most equipped to address those care needs, such as a specialty need. Those are really just a few high-level examples. There is a very long list of examples that were offered in the RFI that I encourage folks to take a look at if you're interested in seeing more there. With that in mind, I'm going to stop there on this particular piece. And again, open it up to hear of any of those ideas, stimulated some additional thoughts and ideas from people on the line today. If you have additional ideas you think the state should consider as it's planning for the 2026 contract. Not seeing any hands raised or comments on this one. Oh, looks like we have a hand raised. I apologize if I pronounce your name wrong, but I think it's Heiken.
It
Megan?
is Heike. Hello, thank you so
Great.
much.
Wonderful.
And I'm with the state of Nevada. I don't even know, typically, I don't have anything to ask here. I was just wondering, for looking at the provider shortages and the promotion of telehealth, right? And I don't know if you said it already because I was, there was something going on here. How will it be with providers that are maybe sitting in another state and can provide telehealth for overcoming all of these shortages? Is that going to be an option, or do they really need to be physically in Nevada when they provide telehealth, or do they just need to follow the acknowledgement or, the licensing that is required in Nevada?
So, hi, this is Stacy. I would just say that we have to follow state law on that. So, I mean, whatever we currently do and allow for, we would be following here. Jamie, I don't know what you would add to that, but I know there's been some discussion about that in the past, and I don't know offhand, but if state law allows us to recognize those licenses, we can do the same on our end. But yeah, we need help on the telehealth for sure.
I would agree with that, Stacy, and definitely one of the key areas that we'll be working through with Manat to improve that category. Thanks, Heike.
Appreciate that question. Thank you. Right. I don't see any other hand raised or questions or comments in the chat. So I think with that, we can probably go to the next thing. Just two more.
Thanks, Julia. Moving on to value-based payments. Nevada Medicaid seeks to prioritize the use of value-based payments with our contracted providers in the expanded managed care program. With the ongoing health disparities and rising costs, the VBPs are critical to ensuring the success and sustainability of the state's Medicaid program. Currently, the division has an incentive program for its MCOs to accelerate the value-based payment arrangements through their bonus incentive program. And I will go ahead and pass it back over to Juliet to talk through the stakeholder feedback for value-based payments.
Great, thank you. So on this slide, you'll see there's a lot of suggestions. I'm not going to go through them all. I know we're coming into the end of our first hour here. And so what I'll do is I'll provide kind of just the higher level themes of this feedback. So first, I would say that stakeholders provided feedback on the question of how MCOs set up value-based arrangements with providers. And that's kind of the first bucket. One of the most common pieces of feedback across stakeholder feedback there was the recommendation to create more standardization in the VBP models across MCOs in order to reduce provider burden and situations where providers are kind of have different types of quality metrics and different types of provider payment agreements with different MCOs. Very similar along that line, we heard from stakeholders who really urged the adoption of standard quality metrics for the VBP models across the state and urged that those metrics were possible align with other programs and other types of incentive programs to streamline the different quality measures that they're focused on and reporting. Stakeholders also recommended that there be more support for providers to help them understand and operate in a VBP environment. So this includes things like trainings, technology, practice management tools for providers who are participating in a value-based payment model, especially those providers who are operating in rural areas. On a kind of different side of this question, stakeholders provided feedback on how the state sets expectations for managed care organizations and how managed care organizations are expected to stand up value-based payment arrangements. Here, for example, stakeholders suggested that the state focus its policies on the total volume of engaged members rather than looking at the total number of providers that are part of a VBP model or having regional targets. So kind of a recommendation to re-examine how the state sets targets for participation in VBP. They also suggested looking at potentially having performance tiers for VBP arrangements for MCOs rather than more binary targets in certain places. And in the rural areas, there were some suggestions to consider having a phased approach for how value-based payment arrangements are set up in rural areas to best support the needs of providers kind of ramping on to those types of arrangements. So here again, you guys all know the drill at this point. We'd like to pause and see what additional thoughts or feedback people have on value-based payment arrangements and how the state might think about those for the 2026 contract. And it can be a comment, a suggestion, it can be a question as well. This is really an opportunity to both ask questions of the state and provide input and suggestions and thoughts. As Jamie noted, we are early in the process and looking forward to hearing suggestions from folks. Not seeing any raised hands yet. So I think perhaps what we'll do, I'm going to talk really slowly in case anyone wants to raise their hand while I'm talking. Perhaps what we'll do is go to the next theme, and if anyone has additional thoughts on value-based payments that come to them over the next few minutes, we'll welcome folks to share those at that moment in time. Oh, but before we do that, Stacey has raised her hand.
I'm sorry. I just wanted to note that there was something in the chat about therapies and value-based payment. It depends on, just to answer that question, it depends on what the program is. If it's designed, for example, let's say we have a value-based payment program where we're trying to reward providers who get certain outcomes and it happens to include therapy services, sure. It could be, it depends on what we're trying to achieve and what the goal is. It depends on the model and the payment structure, which is just a longer, a deeper conversation maybe we can have in the future with stakeholders on what sort of the different structures are for the programs. But as a whole or just individually, therapies would not be targeted at as like VBP on their own. They'd have to be part of some sort of initiative or program. I hope that answers the question.
Okay, Shauna, thank you. As a yes, it does answer the question. I think with that, we can go to our next theme.
Thank you, Juliet. And thank you, Stacey, as always, for jumping in to answer these questions. Social determinants of health and community reinvestments. Recognizing ongoing health disparities and rising costs, Nevada is committed to proactively meeting the needs of the communities served by Medicaid. We're exploring opportunities to help address these social determinants of health or health-related social needs of our members. We want to strengthen our community reinvestment programs through which the plans invest part of their profits back into the communities that they serve, and hoping to increase the community reinvestment that is available or not available, but focused on the rural areas once we expand statewide. And I'll turn it back over to Juliet for the feedback.
Great. This is going to be our last summary of stakeholder feedback today. And so on this one, we'll again walk you through the key themes. So stakeholders suggested extending coverage for a range of SDOH services. I'm not going to go through all of them because there were a fair number in the feedback, and we are, going through all of that and categorizing it. But some of the suggestions that came up, and we've actually touched on some of them earlier in this session today, include thinking about how the state might help support coverage for broadband internet to support access to telehealth, remote patient monitoring, and different types of telehealth services. There were suggestions to continue to explore how the state can continue to support members with affordable housing solutions and housing navigation services. There were a number of callouts for nutritional supports, including home delivered meals and transportation to food pantries. And there were also some recommendations around looking at employment support, such as skills training, education assistance program. So those were some kind of high level suggestions from folks on where the state may look at extending or considering additional coverage for social determinants of health. Stakeholders also stressed the importance of strengthening the community health worker workforce as a key element in expanding access and coverage and support for social determinants of health. And some ideas here really focused around training opportunities as well as workforce retention. For example, there were suggestions for workforce development that might leverage community reinvestment funding to support the building of bigger community health worker workforce in especially in rural communities. And then I'll double click on this last piece, which is prioritizing the use of community reinvestment funding. There were a lot of suggestions from stakeholders on how the state may leverage the use of community reinvestment funding, in which managed care organizations reinvest some of the profits that they make off of some of their profits into the communities in which they operate. And so here we saw a number of different recommendations, including reinvesting specifically in the rural communities. There was a big call out around prioritizing rural investments as part of community reinvestments. There was also suggestions to leverage community reinvestments to perhaps do things that would improve provider networks and invest in provider networks, again, especially in rural areas, including capacity building for primary care providers. There were some suggestions to potentially address transportation issues in various communities via community reinvestment. And then one that I'll note that I mentioned in the SDOH piece as well, that was mentioned a number of times, was potentially looking at how community reinvestments might be leveraged to enhance broadband coverage and enable telehealth, especially in rural and frontier communities. So that brings us to kind of the end of our summary of the feedback that was provided by stakeholders via the request for information and via the different conversations that have happened with the state to date. I will just remind folks again that all of these RFI responses were posted on the website, on the division's website, if anyone wants to take a look at more details that were provided. And we've gone through all of those, very, very helpful feedback, and hope that this summary today was helpful to give you a sense of some of the core themes that we saw. With that, I'm going to pause a final time to see if there's any feedback on specific to social determinants of health and community reinvestments that folks want to double click on or add to this list for the state. Just one final time to remind folks, if you want to raise your hand, if you're in the Zoom platform today, you can just raise your hand using the raise hand feature. If you've joined by phone, you'll want to dial *5 on your dial pad. Not seeing any raised hands or comments at this point. And I think our next section is just an open comment. If you could go to the next slide. Yes, so we move into general public comments and then we'll just transition to that, which is to say, if folks have any feedback they'd like to provide or any questions they'd like to ask around managed care expansion, now is the time. And I see a hand raised from Pat. Oh, maybe not. Maybe that was an accidental hand raise. No, it was a real hand raise. I see a hand raise from Patrick Kelly.
Good afternoon. My name is Pat Kelly. I'm with the Nevada Hospital Association. I just want to first thank you all for providing such great opportunities for stakeholder input. We really do appreciate that. I've provided extensive comments, written comments, and I don't want to go over those, but there are 3 new things that I've identified that I think that should be included in the contracts with the MCOs. The first deals with state-directed payments. 6 critical access hospitals are entitled to receive reimbursement under the new private hospital Medicaid provider fee program. These dollars must pass through an MCO. MCOs should be required to pay the hospitals within a specific time frame, say 5 days from receipt of the funds. Maintaining a positive cash flow is critically important for rural hospitals. Second, MCOs should be required to provide training for providers before the new program goes live. This training should include running test claims before implementation. And third, in many rural communities, local hospitals are the only healthcare facility open for many hours of the day. People come to the ER for a variety of services. Under EMTELA and just our need to service the community, hospitals provide care. MCOs should not be allowed to deny payment to a hospital when the hospital renders care to a Medicaid patient. So once again, thank you for considering these and appreciate everything you're doing on this project. Thank you.
Thank you, Pat. Before we end, how much time do we have, Jamie? Sorry, I'm not tracking the calendar.
We still have about 20 minutes
Okay.
before the end, but I did want to mention that Angela in the chat asked to confirm the proposed start date of January 1, 2026. So just for everyone on the call, yes, January 1, 2026 is the effective date of the next contract, as well as statewide expansion. And I also did put a link in the chat for the statewide managed care webpage that will be continually updated throughout the process.
Thanks, Jamie. And I just want to say too, if you are too shy or couldn't speak for some reason with Teams, you can also send us an email. I don't know, Jamie, if we want to put in the chat the email inbox for folks to send more comments, but we are definitely working fast and furious over the next, I think, 6 to 9, I can't remember, months on developing this, but definitely are looking for as much feedback as we can during this time. And I see we have a hand up. Or maybe there's multiple. Who is that?
I think there are a few.
Okay,
it looks
go
like
ahead.
Sean Ellis was the first one to raise his hand. I'm just jumping in as
Thank you.
back on since her team's crashed. I think she's on, and Sean, I'll pass it to you if that's okay.
Yes, hello, thank you. Something was brought up at the beginning of this call that I'm not sure if I understood the answer or maybe there wasn't one. I think the concern in discussing about this expansion of the MCOs to create more access in rural communities and just throughout the state in general, about the developing of their networks and some of the capitation that may or may not have been happening. And I'm just curious, is there any plans to address those concerns which may cause unintended access going into future contracts with the MCOs?
I'll take this one. Thanks, Sean. I know that So there are a couple things that we've been doing, and when we think about alternative payment models, we want to make sure that they're reasonable. There are instances where a capitation payment, for example, with a large health system can be a win for them. It can also be a win for the state because we're able to manage a population. But there are instances where a capitation payment for a high-risk population where we have very little community resources or a network to not really share data and also manage the population, it's very hard for providers to be successful under those types of models. So one of the things that we're going to be working with Manette is making sure that whatever we develop in terms of allowing plans to do value-based payment models is that they're reasonable and that they're appropriate for the provider and the people that are being served. So I don't want to say that there won't ever be any capitation payment models, because sometimes there are value to those models and actually providers can win, but it depends on if they're appropriate. And so I just want to throw that out there. And also, when we think about that, I would rather us think about bonus payment incentives than capitation payments. That's just sort of where we're at now as a program. We know there's not enough money in the rates as it is, and so we want to be mindful of that. So Sean, I hope that answers your question. I know it's probably a little circular, but we're working on it and making sure that whatever we move forward, we can monitor and ensure is appropriate for the providers.
Thank you.
Thank you for your comment, and apologies if I caused any confusion when my teams crashed there. Technology, what can you do? I think our next person with their hand raised is Amy Hale.
Hello, my name is Amy Hale. I have two comments, but they need to be associated, I guess, kind of two different ways. So the first one, I will say I do work with Johnson & Johnson Innovative Medicines. So this is just addressing the VBA conversation. Something I've seen in my other states that I cover that tend to be more rural states is I really like the idea of addressing all the MCOs as one, because we actually get into some issues about de-identifying data when with individual MCOs or similar plans, there aren't enough patients to technically be considered de-identified. So then we aren't able to enter those contracts because we need minimum numbers on both ends. So I don't know if that's an issue in Nevada, but just something that I've encountered and would love for us to consider. And then my second comment is separate from that. So I am a citizen in Southern Nevada. I am a pharmacist in Nevada. And so I'm speaking only on behalf of myself here. Pharmacists are now licensed under, or not licensed, but are able under fee-for-service Nevada to be providers. Is that I see a lot of conversation about mid-levels, about midwives, but as far as providing medication services to patients, and especially those or in the substance use disorder arena, is that written into this expansion as well?
Stacy, are you able to provide additional information on that? I think
my computer was freezing, so I missed a lot of that. So Jamie, do you mind kind of summarizing the question for me? But in a way, I was not hearing all of that.
I think what she was saying is under fee for service, pharmacists are able to provide some services. And Amy, please add to what I'm understanding your question, and whether or not allowing that through this expansion, whether that would follow through with the expansion to statewide managed care.
So Amy, when we cover anything in our state plan, it applies to both managed care as well as fee for service. There shouldn't be a discrepancy between the two unless there's a specific service for the fee for service population, for example, like a waiver population. But for children, parents, adults without children, and pregnant women, those benefits span both fee for service and managed care. This is just a delivery system. It doesn't change the coverage and how we pay for things. It may change your relationship and how we pay you depending on your contracts with the health plans, but it should not change the benefits that are covered in the provider types.
Okay, great. Thank you. I will have to double check. I thought it was only applicable to fee for service Medicaid were the ones that pharmacists were able to bill currently, and that did not extend into the MCO.
What are you talking about exactly billing for?
So
I mean, they bill all the time. Pharmacists bill all the time in managed care. So I guess I'm not tracking what issue you're talking about.
And yeah, I need to look further into it because I also thought it was only related to fee-for-service Medicaid, but it's basically any service that can be provided by any other level of provider. A pharmacist would need to get paid at parity through that as well. So this is unrelated to like medication dispensing. This would be a pharmacist providing clinical care.
Is that, and you're saying that's covered today in fee-for-service that way?
Pharmacists who are able to get that provider type, yes, there are very few in the state.
It would be, should be the same in managed care. And again, this is just a delivery system. It's not changing the benefit structure and the way providers are paid.
Okay,
Unless
great,
it's the
thank you.
rate.
We'll do an additional call for comments here before we wrap this section.
I would like to mention, I think it's on slide 29 is our email address, that for anyone that wasn't able to ask a question, wasn't comfortable asking a question, if you have any additional feedback, I did put the email address in the chat as well. It's statewidemco@dhcfp.nv.gov. We welcome any feedback or additional questions, comments, as we're working through this expansion and new procurement.
Thank you, Jamie. Sorry.
Thank you, Jamie.
Sorry, Juliet. Are there any other comments? I'm just going to double check real quick. No. Okay. Well, I know we have 10 minutes, so if anyone wants to chime in, please do. We very much appreciate the attendance today and really appreciate everyone's time. And like Jamie said, there'll be other meetings like this. And obviously, in the meantime, if there's more you want to share, we definitely will review it with Manette. And fingers crossed, we meet our timeline. I think we're definitely going to be working hard over the next few months. But very much appreciate all of your feedback and your comments. And definitely will look into some of the issues that folks raised to make sure we're all on the same page as well. So if you felt like you didn't get your question answered and want to follow up directly, please email us and we can also have a side conversation and make sure we're understanding. So thank you. I don't know, Juliet, if you want to add anything, or Jamie.
There's Kai has put in the link to sign up for the statewide managed care notifications listserv. So and he also reposted the statewide managed care webpage in the chat. So definitely recommend taking a look at this website and signing up for that listserv. And we definitely appreciate all of the feedback, like Stacy said. So thank you, everyone, for participating today and joining us in this conversation.
Thank you, guys.
Thank you.
Have a good week or weekend almost. Bye.
Thank you.